We wanted to welcome Jeffrey Staab today for our Grand Rounds. He's going to be talking about 3PD. Dr. Staab is a psychiatrist in the Department of at Mayo Clinic. He's a professor and chair there, and he's published countless articles and books on dizziness and related areas. We're looking forward to hearing your talk.
Well, thanks, Dr. Bigelow. I appreciate your the invitation, and I'm delighted to be with all of you this morning. So what I'm going to do is I'll go ahead and give me just a moment to bring up the talk, and then probably go for about hopefully about 30 or 40 minutes, about 40 minutes or so, to leave some time at the end for questions and discussion. All right. Okay, just a couple with regard to disclosures. The first is I'm not going to talk anything about this. This commercial interest has to do with an AI protocol for triaging patients with dizziness. That's not what we're going to review today. I am going to talk about the use of the two classes of serotonin antidepressants for treating 3PD. Of course, that's off-label, and I'm grateful to all these major agencies that continue to support my research now. We're going to take just a very brief history, look at the diagnostic criteria, evidence that's now emerging about how common 3PD is, and the characteristics of the patients who develop it. I'm going to spend a little bit of time talking about mechanisms before clinical management, just because this is becoming helpful as we're learning more and more about the mechanisms. It's becoming helpful for explaining to patients what's going on with them and how they ended up with chronic dizziness. And then we'll focus on clinical management. This is interestingly, the descriptions of conditions like this date back a long time. So 150 years ago, Carl Westphal, who's a German neurologist, also of the Eidinger-Westphal nucleus in the brain, defined agoraphobia, and his definition, as you'll see, was not the same as the agoraphobia we now know as a psychiatric disorder. Rather, he was looking at why people were having difficulty getting through the marketplaces of 19th century German villages. And of course, the marketplace then was the town square with, all the artisans and farmers and everybody else. So a lot of hubbub in the town square on market day. And what he noticed was that patients described feeling as if they couldn't cross the square or walk along certain streets. And they recognized that there was some fear to that, but didn't really know why. And along with that, this process of feeling as if the sort of a spatial distortion occurred as well. So if we break down those bits, he was really sort of talking about several different things that are related to our locomotion as human beings. First, our movement itself, and then our sense of spatial orientation, this instinctive response that we have that keeps us safe as we move about, and then becoming conscious of our movements, which we're usually not. And he said that was part of all one process, that it wasn't sort of separate things. Now, he wasn't the only one that was paying attention to this. There was actually a debate in the 1870s about amongst these three neurologists and others. Benedict thought it was more of a visual problem, so vertigo, sort of a visual vertigo in the marketplace. Cortis thought it was more of purely a fear response in the marketplace. Now that debate never got settled, and it kind of faded into the background, sort of as psychiatry and ENT and neurology went their separate ways. And then we ended up for a long time with this idea of, sort of a chronic vestibulopathy if you were more on the neurology or ENT side, or psychogenic dizziness if there wasn't a clear structural problem. And then interestingly, about a century after this first debate, then observations which were quite similar started to crop up in the literature in the 1970s. And then from the 80s up through the early 2000s, different groups around the world, including the group that I was working with at the University of Pennsylvania at the time, coined these different clinical syndromes or complex sets of symptoms under the different terms here: phobic postural vertigo with Thomas Brandt's group first, space motion discomfort with Joe Furman and Rolf Jacob at the University of Pittsburgh, Adolfo Bronstein and his group in London with visual vertigo, and then, as I said, our group at Penn. So the Barony Society sort of asked in 2010 us to get together and see whether or not what commonality there was, and whether or not we were really looking at different aspects of a similar syndrome. And that sort of was the genesis of what we now call 3PD. So it became part of the International Classification of Vestibular Disorders. This is the Barony Society has put that together over the last decade. And real quickly, just the diagnostic criteria. So it's a dizziness, unsteadiness, or non-spinning vertigo. So it can be a swaying, rocking type of a vertiginous sensation that is chronic, lasting at least 3 months. And we picked that just to make sure that we're far enough away from the effects of acute precipitating conditions that it was a little clearer that the diagnosis could be made. It does not have to be continuous, but it does have to be present for most of the day and for most days of the month. And then once it settles in, patients can describe increases in their symptoms when they're upright, moving around, also when they're passively moving, like in a vehicle or elevator, and especially on exposure to complex motion environments where the visual stimuli are either moving or in complex patterns. It's a triggered disorder, and I'll go through research on what the precipitants are, but basically it can be triggered by any type of an illness or condition that causes either an acute or recurrent onset of vestibular symptoms or problems with balance. So this triggering of disturbance in locomotion and spatial orientation seems to be the kind of the characteristic of illnesses that can set this off. This last criteria, I want to spend a moment. People sometimes misinterpret this and also misinterpret 3PD as a diagnosis of exclusion. And that's not the way that it's viewed. It's the diagnosis is made by finding these first three elements, A, B, and C, in the patient's history. What this last criterion is meant to do is to make us as diagnosticians, before we settle on 3PD as a diagnosis, is to make sure that it's the right one, that we've accounted for the other aspects of the patient's history, exam, and test findings, and then determine, is 3PD the best diagnosis, the only diagnosis, or possibly part of a coexisting problem. 3PD is also in the ICD-11, even though we are not using ICD-11 in the US right now. The World Health Organization did release it in January of this year. And interestingly, most of the diagnoses in the ICD-11 are narrative in nature, as you see here, rather than bullet points, as we're oftentimes used to for other diagnostic classification systems. So since the definition was published, there have been a number of epidemiologic studies done, and I want to call your attention first to the 3 that were done in general hospital or neurology clinics. So referral clinics, general neurology clinics, and in China, Korea, and Croatia, the ones that were done, there's a rather consistent finding that among patients presenting to general neurology clinics with a complaint of vestibular or balance symptoms, 20% of them had 3PD. This is another interesting group here in Canada who operate at Ottawa Hospital, operate both an acute rapid access clinic that takes patients within a day or two out of the ED, who present with dizziness, and there you see much more sort of acute structural problems, vestibular migraine, those kinds of things, very little functional or psychiatric problems. But once you get to their chronic clinic, so it's a specific clinic setups to treat patients with chronic dizziness, then 3PD becomes a major comorbidity especially. So not always the sole diagnosis, but very frequently comorbid. The other thing that these clinical epidemiologic studies show us is the profile of patients. So 2-to-1 women to men. In adults, in the mid 50s is when patients typically present. Although all of these studies indicate that it can hit in adolescence to late life. And here, a recent study from Boston Children's Hospital showing that it's a little bit more female predominant among adolescents. With an average age presenting at around 15 years. So it's also classified as a functional vestibular disorder. And so again, this is sort of another back to the future. What do we mean by functional? The term functional has been around for 200 years in medicine and meant differently than what I was trained to think of it. And many people were to think of it as sort of as a synonym for psychogenic or psychosomatic. Originally, this is what it meant, a change in functioning of an organ system or a change in its mode of action, not directly related to a structural deficit. So we've sort of repurposed that, not only in neurotology, but GI doctors have done that. Our colleagues in GI medicine with all the functional GI disorders and many other specialists now are defining syndromes that are more functional than structural in nature. And Thomas Brandt and Mariana Dietrich and I wrote a chapter kind of trying to tease this out a little bit a couple of years back. And instead of thinking it in sort of a dichotomous structure on the one hand and psychogenic on the other, it's rather that we look for, as we evaluate a patient, what structural metabolic problems may be present, what psychiatric or psychological problems may be present, and is there evidence of a functional change or functional disorder. And so rather than approaching this in a rule out way, rule out all the structural things and you're left with these, it's systematically going through the patient's history, exam findings, and test results to say, are there structural things present, yes or no? Are there psychological things present, yes or no? And are there functional changes present, yes or no? And layering those three things together allows us to come up with a final diagnostic picture for our patients. So if we're going to say, though, if we're going to hold ourselves accountable for calling this a functional disorder and saying that there are changes in the mode of action, what are they? And I'm going to briefly go through some of the data that suggests there are changes in postural control, spatial orientation, and in changes in brain functioning that support those activities. So here's the research I mentioned about precipitants. So 4 studies done in adults and 1 in children. And what you can see is that, roughly speaking, about 20 to 25% of the precipitants of 3PD are acute or episodic vestibular syndromes. And that's important because patients with 3PD end up coming to neurologists, neurotologists, and otologists because their chief complaint is dizziness. But when we see them, only about a quarter or so will have had a neurotologic or peripheral neurotologic disorder as their trigger. There are other things, so we end up seeing these patients who may have had a multiplicity of other kinds of problems that were their initial triggers. Anxiety disorders in this quarter range. John Watterson's group in Melbourne, higher than the others. It may just be the patient flow to their practice versus the ones in Thomas Brandt's group in Germany and ours here in Rochester. Migraine comes up pretty frequently, about 20-ish% range, and then a smattering of other things, traumatic brain injury, so mild concussion, dysautonomias like postural orthostatic tachycardia syndrome or autonomic dysfunction of older age. And then a variety of different medical conditions, often dysrhythmias or metabolic kinds of disorders. So again, as I mentioned before, what do all of these different things share is they all have the ability to cause dizziness, vertiginous or unsteady sensations, or disrupt balance. Children, the things are a little bit different. This group also allowed, you see that adds up to more than 100. That's because they listed more than one potential precipitant, oftentimes a migrainous presentation with a ear disease. So then the question is, well, okay, if you've got that precipitant, then why does this become chronic? And this is research done, as you can see, before the definition of 3PD. So it was really looking not so much at 3PD specifically, but rather why do people develop chronic persistent dizziness? The description of that dizziness is much in keeping with the description of the kind of vestibular symptoms in 3PD. But again, these studies weren't specifically related to that. So all four of them did something similar, that is, gather a group of patients who had an acute vestibular syndrome, either neuritis or BPPV, and then follow them over 3 to 12 months differently in the different studies. And the majority of patients in all of those studies recovered, became asymptomatic. But somewhere around a third began to continue to have chronic dizziness, not the acute vertigo, but this sort of swaying, rocking, unsteady, dizzy sensation. The interesting thing was that when you looked at their long-term outcome with regard to vestibular testing, the majority of them, from a peripheral standpoint, had compensated for their initial insult. So 90% of them had compensated, and yet they were still dizzy. And so what this group, Gottman in Germany, did was look at, well, what is the course? And what they found was that people who responded to this acute vestibular event with anxiety, that type of anxiety was becoming very vigilant about their body and their movements, and also to beginning to think catastrophic about, well, what is this going to amount to? Is this ever going to get better? Am I going to be able to go back to work? Those kind of sort of worrisome thoughts, that combination of increased body vigilance and increased worry about the nature of the illness was present in the majority of people who began to have persistent problems. And so this combination of an acute vestibular, not necessarily vestibular, but this event that causes vestibular symptoms, plus that anxious response, seems to be the sort of the nasty mix that can set patients along the path to chronic dizziness. All right, let's talk a little bit about some of those functional shifts. So this is a study done from Switzerland back in this chronic subjective dizziness days. This is just platform posturography, static posturography at ground level, normal sway path. And patients with CSD, again, one of the precursors of 3PD, had two patterns. What they did was they stiffened their lower body. And some people, if they stiffened their lower body, they would stand more ramrod straight and therefore have a smaller sway path. Others, if they stiffened strongly enough in their legs, the postural sway would transfer to their upper body. So you would have stiff-legged, functional sway of the upper body. And that's what you see here. Brandt's group looked at changes in gait in patients with phobic postural vertigo, again, another one of the precursors. And in Minnesota, we call this the walking on ice skate. I don't know what you're going to talk about it in Los Angeles, maybe the walking on slippery surface, something like that. But in the walking on ice skate, our patients get that. They've sort of slowed down, put their feet further apart, look at the ground, and move more slowly. So the physiology is co-contraction of the ankle and leg muscles that can transfer the natural body sway to the upper body rather than in the legs where it normally is. You can also see this if you put people on the edge of a platform at height, and in those who have fear of falling or fear of height. So it's a process of physiologic shift that can occur in normal individuals under postural threat and in patients with either fears of movement or heights, and then here in these precursors of triple PD. The second shift has to do with our spatial orientation and integration. And here it's a shift to relying more on visual stimuli than vestibular or proprioceptive ones. Data here from Adolfo Bronstein's group, where they followed patients after vestibular neuritis for 6 months. You can see that they compared then those who returned to normal in terms of symptoms versus those who still had high scores on the dizziness handicap inventory. I was able to see some of these patients with his team when I visited his laboratory. These folks are very much 3PD types of patients. So under static conditions, their subjective visual vertical is just fine. Same as those who had returned to normal. But once you start to swirl the background and give them that complex visual background, then it deteriorates their ability to use visual cues to have a proper sense of upright orientation with respect to gravity. A different, this Italian group did it a little bit differently. They did this here. They did the head impulse test while asking people to tell them which direction the opening was on this center optotype. And again, patients with 3PD could do that just fine when the background was static, but once it began to turn, then their performance on this task, which they called the functional HIT test, deteriorated. So it says that patients are not only relying on visual cues more, but then when they're in a situation in which the visual surround is complex or moving, it causes disorientation. Put those two things together and you get poor performance across the board on a platform on the dynamic posturography. Again, this is in the old days, we would have called this a functional, or some people actually even called it a malingering pattern, the across the board pattern. But we see that repeatedly. Two different studies, one done in Brazil and one done by our team here, showed this kind of a thing, different from either normal individuals or those who had recovered from an acute vestibular syndrome. This is an intriguing study from Chile, done a couple of years back. This test, the water maze test, is usually done with rodents, but now it's virtual and can be done in humans. And let me just take you through what this is. So there's 3 steps to this. There's sort of the test trials or the practice trials, in which the person is placed here. This is a water tank. In real life with rodents, it's an actual tank of water with a platform that sticks up above the water that the animal can rest on. And the person is placed here, or the animal placed here, and then has these orienting cues to kind of guide them around the tank. And the idea is to go from the initial spot over to the platform. So 4 trials of practice to start here, get there. Then the test trials are the ones in which the platform is in animals. In the animals, it's actually reduced below the water surface, so they can't see it. In the virtual reality, also becomes invisible. And the target and the task is still the same. In the B trial, start here, get there. In the C trials, it's start anywhere and still end up where the platform was. So what they did was, here's normal people. They do it just fine. You can see hit quite easily, hit the platform. People with peripheral vestibular illness have a degradation, but still do reasonably well getting to the platform in both the B and C trials. But people with 3PD seem to wander aimlessly. They just do not have that orientation in space that can get them from a starting point to a target point. So that's a symptom that people will sometimes say is they just feel disoriented in space. All right, there have been now more than a dozen functional MRI studies and other imaging studies, functional imaging studies of patients, sorry about that, with 3PD. I'm going to just give you a couple of summary ones. And the interesting finding is that the vestibular cortical regions and other areas that support spatial orientation and locomotion are all decreased in their activity compared to normal, and decreased in their connectivity with one another compared to normal. So the cortical functioning is reduced, and the network integration of these various systems that support spatial orientation and locomotion is also reduced compared to normal. And these are in resting state and in studies in which patients were either given a vestibular stimulus, namely the VEMP type click, or virtual reality motion settings. This one from Korea also identified changes in hippocampal conductivity. So interestingly, if you look, there is a little bit of increased connectivity. That's associated with modest levels, so not terrible levels, but modest levels of anxiety that connect frontal lobe regions to the occipital cortex, possibly the subserving that visual dependency. But then once you control for that low level of anxiety, then what you see is this significant decrease in the connectivity of the hippocampus to other areas of the brain. And since the hippocampus is involved in our spatial navigation, so namely where am I in space, egocentric, where am I in space, and also in our working memory, that may well be sort of the underlying process that is responsible for some of that poor performance on the water maze test. All right, now we put this all together and tell patients this story. You had an acute event, could have been vestibular, other medical, it could have been acute anxiety and distress. You made some shifts that you had to make when your inner ear wasn't working, when you're having recurrent episodes of vestibular migraine, when your blood sugar was uncontrolled or whatever it may have been, and you became more focused on using vision and developing these sort of stiffer, high risk, if you will, the walking on ice kind of strategies, and became more vigilant about your environment. And then under most circumstances, people recover. But if you got a little tuned in to what was going on, more vigilant about your body and more worried about what was going to become of you, then you got sort of stuck in these acute adaptations and didn't sort of reset. And so now when you have to move, when you have to be in visually complex situations, your brain is processing those stimuli differently, you're more aware of them, and it's maintaining you in these high-risk postural control strategies. And then, a portion of patients, about 60% or so, will develop some anxiety or depressive diagnoses, diagnosable illnesses. And as we saw, this spatial orientation becomes disrupted. And this is a story that people understand. They oftentimes will say, 4 years ago, I woke up with spinning vertigo, spent 3 weeks on the couch, and I've been dizzy ever since. I don't have the spinning vertigo anymore, but I'm dizzy and can't tolerate being in busy places. And so they see in their own history this sort of temporal change in their clinical course. Okay, let's a few minutes then on the clinical management, making the diagnoses. I'm going to go over a few challenges that come up, sort of clinical pearls on challenges that we and others face, and then we'll talk about some treatment. Okay, case example: 44-year-old man woke up, kind of like what I just said, spinning vertigo, gait unsteadiness, not postural or positional, no other features, neurologic or otologic in origin, and gradual resolution of the acute vestibular symptoms over a few weeks. But then 4 years now, the fluctuating, swaying and rocking unsteadiness, worse with his own movement, worse in busy places, can't use electronic screens. So if we think about this, we've got two sets of symptoms. We've got the acute vestibular syndrome and we've got the chronic vestibular syndrome. So what might the diagnosis be? Well, let's say on testing, he has a right caloric deficit, but otherwise normal. And including on things like, a head impulse test or head shake test. And so in that case, we would say he's got an acute vestibulopathy 4 years ago. He's compensated and then developed 3PD. If we put a little twist on that history and he says, yeah, I've got all that going on, but if I move my head really fast, even for a moment, I just get thrown off for a few seconds and then I get steady myself again. And this time in the office, he's got the positive head impulse and head shake tests. In that case, we'd say he's not compensated well and he has 3PD. And we'll go through a couple of the key points. Why can we say that he's got both of those things in just a second? All right. One of the things that bothers both patients and physicians and other other clinicians in making the diagnosis of 3PD is that it's history alone, and how trustworthy is that? How well can we make a diagnosis based on history alone? Of course, we've got this other diagnosis over here, migraine, that's also based on history alone. But we looked at during the time in which the Barany committee was looking at creating the diagnostic criteria, we gathered these data from 400 patients that we'd seen at Mayo, and looked at the pattern of symptoms. So here you see the vertigo in orange, unsteadiness in the aqua, and dizziness in pink, and whether patients described those sets of symptoms as lasting for seconds, minutes, hours, days, or more continuously. So of course, 3PD was the unsteadiness and dizziness that lasts for weeks to months. There's your core typical symptoms of Bppv. Again, same with attacks of Meniere's disease, and migraine, as we know, is a little bit of a chameleon, so it's got a broad range of symptoms. But we also then had patients who said, I have this and that. So these few seconds of vertigo, but then I feel dizzy all the time, or I have attacks of, fluctuating hearing and vertigo, and then in between I feel dizzy all the time. And what that proved to be was comorbid 3PD. So even in patients who had comorbid illness, it was possible to pick out with high sensitivity and specificity. The sensitivity and specificity here was in the mid 80s of using the diagnostic criteria for 3PD to detect the existence of this of 3PD, even when these other illnesses were present. So in other words, we really can rely on the history when it's gathered properly. So just want to take you through these particular challenges and what we look for both on history and exam to try and tease out whether one or the other or both of these problems are present. Okay, so let's start with this. This is that case that I just said. So what we ask for in history is we say, okay, apart from the day in and day out dizziness, if you move your head quickly or you get bumped or you're driving in the car and it hits a pothole, what does that do anything to you? And with people who described, sort of that acute flare of a vertiginous or unsteadiness sensation that lasts for a few seconds until the movement stops, suggests maybe that they're not well compensated for the original deficit. And then we flip the question and we say, okay, when you're sitting still, so you aren't moving, but you're in a place where there's a lot of hubbub around you, a lot of movement, flashing lights, patterns, what does that do to you? And if the person says, well, that makes me feel dizzier all the time, then that suggests the 3PD, because we wouldn't expect a peripheral illness to cause an increase in symptoms if the person's not moving their head. And so then on exam, again, looking for the presence of poor compensation or the presence of 3P or of Bppv. And the implication of this, if both conditions are found, is that the person may need to do both compensation exercises for their deficit, as well as the kind of gradually building their tolerance for motion that we use with 3PD. This is a tough one with vestibular migraine. So keeping in mind that right now, the only definition of vestibular migraine is an episodic condition, not a chronic one. That doesn't necessarily absolutely exclude the fact that it could be a chronic vestibular migraine, but it's not been well defined or characterized yet. So what we look for when somebody has a migrainous history or is telling us that they have sort of two sets of symptoms, recurrent attacks of vertigo or unsteadiness, that have some migrainous features, not necessarily a rip-roaring headache, but, photophobia, phonophobia, those kinds of things. Then we really do pay attention to whether or not that's a vestibular migraine pattern. And then, again, that chronic unsteadiness. So this is a person who says, I've got the day in and day out swaying and rocking, and 3 times a month I get laid low with attacks of vertigo, that I would just want to go in a quiet, dark room, be still and turn out the lights. And so, this again is something that we've paid attention to. We just recently completed a clinical trial of treatment for vestibular migraine, and we collected data on 3PD. We'll get that out for presentation publication later this year. But when the two are together, the number of headache days is doubled, the number of dizziness days is quadrupled. So we think that it's not just a chronic vestibular migraine alone. The other reason why we think that is when we treat or we receive patients who have been treated just for vestibular migraine, they usually don't get better until we add the therapy for 3PD. So again, down here, that's really the implication, is that if these two are running together, we really need a management strategy that covers both of them. All right. How about Meniere's disease? This has been a curious observation of not only us but others around the world, and that is that, you know, we know that Meniere's is characterized by these major attacks of vertigo, but there are also people who either in between untreated vertigo or untreated Meniere's, or when they have had adequate treatment for their acute major vertigo attacks, have these interictal or chronic symptoms. You know, that and it can have a couple of different patterns. So the chronic dizziness and insensitivity, sort of the typical PPPD symptoms. As any other peripheral illness, the head motion induced symptoms to suggest maybe that they haven't compensated for a peripheral deficit that they may have developed. And then there's this curious pattern in which a number of patients will say, my big vertigo attacks are gone since I had, you know, transtympanic steroids or gentamicin or endolymphatic surgery or whatever the treatment may have been that was necessary to control that. But I still get these short little spikes of vertigo. They last a few seconds, a few minutes. They come and go. They're pretty frequent. We don't know what the cause of that is. But these two groups, one in Japan and one in Turkey, have published small case series that suggest that the serotonergic medications like Zoloft or sertraline can actually decrease that, and we've seen that too in our practice. So the implication there is that we work really closely with our surgical otologists. You know, when patients are presenting with this, to kind of make a determination of what treatment strategy we may need. And if it's unclear, we really suggest that patients go through a good course of treatment for 3PD first, and then reevaluate how bad the episodic attacks of vertigo are. And a number of patients say, the day in and day out dizziness is better. I'm functioning now. If I get an acute vertigo attack 3-4 times a year, I really don't want surgery or anything else for that. I can deal with that. And others whose vertigo does need to be better controlled are in a better spot for improved surgical outcomes if they don't have active chronic dizziness going in to the surgical procedure and the post-surgical recovery period. So that's something where we've really kind of worked closely together across the surgical and behavioral medicine side. Anxiety disorders. Anxiety is very common. More than 60% of patients with 3PD either will have anxiety or develop it. And so it comes either as sort of the chronic worry wart or the person who's having recurrent panic attacks. The thing to keep in mind here is that anxiety disorders have long been associated with minor abnormalities on vestibular laboratory tests. So if the vestibular laboratory tests come back with a little bit of a little off here or a little off there, but not really in a clear diagnostic pattern, you know, don't overcall that as evidence of a central or peripheral deficit. And the other implication is we may need more aggressive treatment for them with psychotherapy and medications than if it's uncomplicated 3PD alone. All right, a few red flags. If somebody's got a slow, insidious onset of unsteadiness, dizziness, insecurity of balance, that can lead to 3PD, but we really have to pay attention to whether it's a degenerative disorder, either of the vestibular labyrinth or of the brain. So a little cautious with that slow, insidious onset. Oftentimes we'll follow those patients for a little bit longer to let time help us with that diagnosis. And then falls, overt gait disturbance, including falls, are not part of 3PD. So if a person comes and says that they're having a lot of falls or near falls, again, look for structural neurotologic causes of falls, look for cardiovascular autonomic disorders, and also people can develop functional gait disorders with 3PD. And then this last one, is a common one that we see, and that is that patients will come with a leading complaint of chronic dizziness, but they also have a lot of other chronic symptoms, chronic fatigue, chronic pain. And when we see that kind of combination of I've got just 3, 4, 5 chronic symptoms that are really burdensome to me, even if the vestibular ones match 3PD, we back up and say this is more of these somatic symptom or somatic a somatization kind of a pictures and better handled as a rehabilitation as we would for patients with chronic pain. All right, treatment. So physical therapy, we tell patients you may take medicines or not, you may do psychotherapy or not, but you've got to do physical therapy. And that is to normalize stance and gait, get back in that natural, relaxed, normal weight distribution, build up tolerance for head and eye movement, build up tolerance for visual stimuli. This is the tougher one. I tell patients that this is a 3 to 6 month task. So if somebody sees me today, I'm going to tell them this is your fall and winter project in order to get better, because it does take that persistence. Some studies show that a vestibular therapy alone can reduce patient symptoms from this moderate to severe level down to a mild level in about half or more of individuals. So even just a vestibular therapy alone can be effective for a substantial portion of patients. Studies with this we stumbled onto years ago. Basically, we were seeing patients with a lot of depression and anxiety. We said, not exactly sure what to make of your dizziness, but let's treat the depression and anxiety and get you feeling better that way. And they came back and said, I'm not dizzy. And so we sort of ran with that, as did a group in Japan who made that same observation kind of independently from us. So these studies continue to be done. The last one was just published by Jisoo Kim's group in Korea, and they're actually quite consistent over these now nearly 2 decades. And that is that patients, again, using medications alone, here in blue, will have a decrease from this moderate to severe level on the dizziness handicap inventory down to the mild level. So from impairing symptoms to nagging symptoms, which allows them to pretty much live their life as long as they don't stay caught up in the residual symptoms that they have. Adding CBT here, this study from China shows that patients get better faster and need less medicine. Overall, if you take all comers and treat them with medication alone, 2/3 will have this level of improvement. If patients can tolerate a full trial of 8 or more weeks, 5 out of 6 will get this significant improvement in symptoms. There haven't been any fully developed level 1 randomized controlled trials, but there are now 9 open trials in this one randomized trial from China, total more than 500 patients, showing that all 6 of the SSRIs and a couple of the SNRIs that have been tested can treat this PPPD type of dizziness. And interestingly, any anxiety or depression that exists, patients do not have to have an improvement in, do not have to have anxiety or depressive symptoms, and don't have to have an improvement in those to see a benefit from dizziness. Although if all 3 of them are present, they usually do improve simultaneously. So it's not acting specifically through an anxiety mechanism that is bringing the dizziness under control. All right, I'll leave this for you to take a look at in reference. Dr. Bigelow can share these slides with you. Here's some just some dosing strategies that you can use. These are the 3 most common medications that we use. Typically, if there's migraine coexisting, we use venlafaxine because it is there's data to support it as a migraine prophylactic. Psychotherapy, initial trials back in the phobic postural vertigo days weren't all that impressive. Patients might have a little benefit at the beginning, but not sustained. More recent trials have shown that cognitive behavioral therapy and sort of its modern developments, some modern adaptations of it, can be effective both as a sole treatment and in particularly when used with SSRIs or vestibular habituation. So worthwhile seeing having psychologists or therapists that can help you with that. They do have to be familiar a little bit with the dizziness, because I tell patients, if you just call up a therapist and say, I need help with my dizziness, they'll say, I don't do dizziness. So helping patients lead with the kind of anxious comorbidity helps them get in the door of working with the therapist. So to wrap things up then, we do now have the 2 formal sets of diagnostic criteria. Among patients with chronic dizziness, this is the most common diagnosis in tertiary settings with about 1 in 5. But in dedicated units, about double that in terms of at least being a coexisting condition. And then we've got this sort of change in mode of action and spatial orientation and locomotion that we talked about. And we have our 3 treatment strategies, which can be used either independently or together. So we'll stop there.
Hello, my name is Dr. Kevin Peng, neurotologist here at the House Institute. Thank you for watching this video. The House Institute provides free educational videos for hearing health professionals worldwide. To help support videos like these and other educational efforts, please consider donating by clicking the link in the description box below. Your generous support allows us to keep videos like these at no cost for you and others. Thank you.